Welcome back to Core Anesthesia. Whether you are a student prepping for tests and boards or a CRNA here to earn CEUs, we are glad you've joined us. For more about us, make sure to check us out on Instagram at Core Anesthesia and online at coreanesthesia.com.
Welcome back to Core Anesthesia. I'm Cole here with Tanner, and we are actually together live in person. We are both in Chicago at the Region 3 conference. We are rarely in person when we record these episodes together, so we just figured let's record one while we're together this morning. We're actually getting ready to go present in about an hour, so we're going to warm up our voices, do a recording here, do an episode. We're really excited to do a just question-based episode. We've had a lot of requests to just do an episode where we go through questions, explain the rationale, how would we, from a test-taking standpoint, got into that answer, what's the rationale of why that is the correct answer, etc.
Yeah, so hopefully this is just a good review for you, whether you're preparing for boards or maybe this is just lining up with the test taking that you're going through right now. But we've had lots of requests, like Cole said, about this. And we just think this is a cool way to make use of your time while you're on the go. And let's get some question prep in. So let's just dive right in. The format of this, we're going to go through the question. We're going to go through the answers to give you a little bit of time to answer it. We'll discuss the answer afterwards. So when you hear a long pause, don't cancel us or fast forward. Just that's the time we're purposely putting in there so that you have time to answer it. All right, question number 1. In an obese patient, all of the following lung volumes / capacities decrease except, so in an obese patient, all the following lung capacities decrease except expiratory reserve volume, ERV, total lung capacity, functional residual capacity, or D, closing capacity. So again, all of these in obese patients will decrease except expiratory reserve volume, total lung capacity, functional residual capacity, or closing capacity. And the correct answer is closing capacity.
So for this question, you basically have to put yourself in the shoes of looking at the 4 answer choices, and anytime I approach a question, I'm always trying to figure out what is the root cause of the question. What is it trying to ask me? And in this case, what separates an obese patient from other special populations? And in an obese patient, what's going to happen is you have extra adipose tissue that is pressing on the thoracic cavity and causing a constant pressure that is acting against the lungs' ability to expand. And so you have to think everything is going to be closed or decrease or diminish in terms of the amount of volume that there can be there. So first you have expiratory reserve volume. So in this case, do I have extra volume reserved that I have to ventilate back and forth? Well, no, because I'm decreasing that. I'm having more adipose tissue. Same thing with the total lung capacity in B. That the same exact rationale there. You have things that are pressing down onto the thoracic cavity. It's going to decrease my total lung capacity, the ability that I have to take a completely deep breath. So C is again the same type of rationale. You have the functional residual capacity that is going to be decreased because I have less reserve, so to speak. I have less of that functional residual capacity, the amount that I still have in my lungs after I take a deep exhale. And that is just simply because, again, you have all that adipose tissue pressing down. So just using that root analysis, you know it has to be D, closing capacity, even if you have no idea what closing capacity is. So closing capacity is basically the lung volume in which the small airways are going to start to close. So it does not decrease then in an obese patient. It actually is going to stay there or become slightly elevated. So you have this lung volume at which how much volume is still in the lungs when I'm exhaling before my small airways start to close. And this is going to cause air trapping then because you're going to have still volume further into the lungs that can't get out because those small airways are starting to close due to that extra adipose tissue and pressure closing onto the lungs and basically occluding those small airways. So next, we have a second question. You have a patient with severe asthma who uses albuterol 4 times a week. Which of the following medications should be avoided in this patient? So again, you have a patient with severe asthma. They use albuterol 4 times a week. Which of the following medications should you avoid in this patient? A, succinylcholine, B, rocuronium, C, sevoflurane, or D, cisatracurium. So that's succinylcholine, rocuronium, sevoflurane, or cisatracurium.
Do we have a license to hum the Jeopardy music?
I don't know.
Don't come after us, Jeopardy. All right, so the answer, like Cole said, is succinylcholine. And so when we're looking at this, the main thing that we need to think about is histamine release. So of the four, succinylcholine is going to be the one that causes histamine release. Histamine release ultimately leads to bronchoconstriction and can also cause bronchospasm. This patient is already using albuterol. They're already at a higher risk for these airway responses. So anything that's going to release histamine, we're going to want to avoid. You should also keep in mind with using albuterol, it's not, as forefront as the histamine release, but you need to remember also that hyperkalemia can be caused by albuterol use. And so succinylcholine can also cause that potassium to be increased. And so it would be a very low risk, but it's also something that you should just keep in the back of your mind for why you would not want to give that medication. All right, next question. Fentanyl, a basic drug, has a pKa of 8.4. If a patient has a pH of 7.2, how will the administration of this agent alter its therapeutic event? A, the fentanyl will be less effective because more of the drug exists in the ionized state and cannot cross the cell membrane to produce the therapeutic event. B, the fentanyl will be more effective because more of the drug exists in non-ionized state and cannot cross the cell membrane to produce its therapeutic effect. The fentanyl will be more effective because more of the drug exists in an ionized state and cannot cross the cell membrane to produce its therapeutic effect. Lastly, the fentanyl will be more effective because more of the drug exists in a non-ionized state and cannot cross the cell membrane to produce its therapeutic effect.
So we may not have Jeopardy licensing, but going through school, we always used Kahoot.
Oh, yeah. It's a bop.
This was every quiz day. This is what we had. All right. So for this one, the answer is A, that fentanyl will be less effective because more of the drug exists in an ionized state and cannot cross the cell membrane to produce its therapeutic effect. So let's understand how this actually works. So when you have a medication that has a pKa value that is vastly different than the pH value. So in this case, we're over a full point. We're at a pH of 7.2 and a pKa of 8.4. So understanding an ionized and an unionized state of the medication and when it becomes more active, it can cross the cell membrane, etc., plays a big role into if this medication is actually going to do the job that you want. And so when it comes to basic drugs, they are more ionized the further away they are from the patient's pH. So because we have an already basic drug, fentanyl, at 8.4 on pKa, and you have a typical pH of 7.35 to 7.45 for the blood physiology, and now you have an acidotic patient that's 7.2, you're getting further away from that pKa value. So as a result, more of the fentanyl now is going to be in the ionized state. So this results, more ionization of that drug in that acidic pH means now less drug is available to cross the cell membrane. Why? Because only the non-ionized version is lipophilic and is able to transfer and go across that cell membrane and actually get its effect where we want it to do. So if you have the patient that's more acidic, more of the medication now is going to be ionized, which means it's basically trapped there. It's not going to be able to cross into the cell and actually do what we want. So one way you could tackle this is B, C, and D all said it'll be more effective. So because of that, if you had no idea at all, your best bet's to go with the one that is different than the other three. And in this case, you have three that are similar from that standpoint, but that's not always the case. You have to dive in more and actually understand more of the root cause of what that question's asking. But if you're in complete doubt on a test, that is usually, for me, a good estimated guess is doing an answer choice that is seemingly different than the other three. Another strategy I use for this is if you have two answer choices that seem to be opposite of each other, then you know usually that it's going to be one of those two answer choices. But then also, if you have three answer choices that point towards the same direction. In this case, it's really obvious. All three said more effective, more effective, more effective. But if you have different wording answers but point towards the same direction, you know that those both can't be the correct answer, because if one of those is correct, the other one would have had to be correct as well. And so usually if that's the case on an exam, I have no idea what the question is really asking about. It's an estimated guess. I'll use that test taking strategy just to eliminate wrong answers. So then next we have, which of the following correctly identifies the mechanism of action of magnesium sulfate regarding its use in pain management? A, it stimulates the NMDA receptors, enhancing pain signaling. B, it promotes the release of endorphins, leading to analgesia. C, it blocks calcium influx at the NMDA receptors, reducing central sensitization. Or D, it directly inhibits COX enzymes to reduce inflammation.
Oh yeah, there's the music. For all of you that are listening to this, we're, like Cole said, we're in Chicago, but I'm eating Stan's Donuts currently, and they are, this is your first time having Stan's, right?
Oh, they're fantastic.
They're amazing.
Problem is, Tanner brought these chocolate ones in while I'm in my dress suit, ready to get up and present.
Yeah, I already spilled coffee on my shirt. We're not rolling with it this morning, but I want to know from anybody in Chicago if Stan's is like, is this the pinnacle, or is there something else I should be trying next time in town? All right. So the correct answer on this one is C. It blocks calcium influx at the NMDA receptors, reducing central sensitization. So, the first one said it stimulates NMDA receptors. It does not stimulate the NMDA receptors. It is going to be an antagonist. The next one, it promotes the release of endorphins. There are a few analgesic agents that will promote endorphin release. MAG is not going to be one of them. The mechanism of action here is basically it creates a plug here on the NMDA receptor, which will block that calcium influx. And so then your action potential is not able to continue. Thanks, Mom. I don't know if you guys heard that camera go off while I was recording, but you taking a photo for the podcast? Yeah. We'll post it to Instagram. You make sure to go look for it. So that's going to be the answer. There is the magnesium is going to be blocking that NMDA receptor, basically creating a plug there that prevents the calcium from going through, and therefore you do not get the signal conduction. All right, this question, what is the function of warfarin therapy as it relates to the clotting cascade? What is the function of warfarin therapy as it relates to the clotting cascade? Warfarin inhibits vitamin K, reductase complex 1, so VKORC1, which makes clotting factors inactive. Warfarin agonizes vitamin K reductase complex 1, which inactivates clotting factors. Warfarin combines with antithrombin 3 along the endothelial wall to remove thrombin from circulation. Or D, warfarin inhibits antithrombin 3 along the endothelial wall to remove thrombin from circulation. So this is interesting because the four answers here, you basically have two opposites. So if you're going with Cole's test-taking strategies, this gets you down to not really any better because you got two sets of opposites.
Yeah, and again, that test taking strategy is not going to be foul-proof. You can't just go into a test not knowing any content and expect it to work every time. But when it works, it's nice. When it's eligible, in this case, you're right, Tanner, it's not going to help you very much. So let's look at this. First of all, the correct answer is going to be A, and that warfarin will inhibit the vitamin K reductase complex 1, and that's going to make clotting factors inactive. And so hopefully, if you know warfarin and what the end goal here is going to be, it's going to thin the blood. So it's going to make clotting factors inactive, so we're not going to be able to clot as well. So you know from a get-go that the end goal should be correct with A. The question just becomes, is that the way in which it does it? So if you're going through this for the first time, you know the end result of A is correct, but is the route correct? So we'll hold off on that. You go down to B, and you know that it agonizes the vitamin K reductase complex 1, which then inactivates clotting factors. So to Tanner's point, both of those are talking about the end result of inactivating the clotting factors. So the question is it because it inhibits that complex or it agonizes that complex. And so the result, the rationale behind this is that the mechanism of action of warfarin is to inhibit that complex, which then inhibits vitamin K from returning to its active form. And without vitamin K, the coagulation process can't take place then. So it's essential in adding, the vitamin K is essential in adding a carboxyl group to those clotting factors produced by the liver. So you're talking about clotting factor 2, 7, 9, and 10. And without it, these factors are not going to function properly and the clotting is impaired. So if we're blocking that vitamin K, we're going to block those clotting factors from working properly. So next we have, which of the following supports the reason that a second action potential cannot be elicited during the refractory period? So which of the following supports the reason that a second action potential cannot be elicited during the refractory period? A, acetylcholine is being released into the synaptic cleft at this time. B, the sodium channels are inactive at this time. C, the calcium ion influx is considered to decrease the excitability of a second action potential. Or D, the myelin sheath prevents the nerve impulse from transmitting the second action potential through the axon.
All right, so the correct answer here is B. The sodium channels are inactivated at this time. So if you remember basically the lifespan of these action potentials, right after the action potential is initiated, the sodium channels will become inactivated. So it doesn't matter how much excitatory signal is coming down these channels. These channels are in the inactivated state, and there's nothing that's going to cause any action potential to move through those channels. So during the refractory period, there is no circumstances that the membrane will be able to depolarize because the actual channels, sodium channels, are inactivated, and so there's no way for signal to come down or for that membrane to depolarize. All right, which cardiac reflex is elicited as a result of increased volume of blood in the heart, which causes sympathetic nervous system stimulation? Cardiac reflex is elicited as part of an increased volume of blood in the heart. This causes a sympathetic nervous system stimulation. Cushing's reflex, Bainbridge reflex, celiac reflex, or the Biesel-Jarrus reflex. This music kind of gives me like PTSD.
Dude, I'm telling you. This brings back the times where I was stressed out going through tests and quizzes and no sleep. And all right, so we are talking about the Bainbridge reflex here. The correct answer is B, Bainbridge reflex. So the way I remember this is I think more water under the bridge. We're going to push more water through. I don't know how you like to remember it, but basically the Bainbridge reflex is elicited in response to an increased volume of blood in the heart, particularly in the atria of the heart. So when the atria gets stretched due to an increased venous return coming back into that right atrium, it's then going to cause receptors in that atrium to detect this change. They send signals to the vagus nerve, which goes to the brain and tells the sympathetic nervous system to be activated to increase the heart rate. And so basically what it's trying to do is keep that fluid moving through the heart. It's recognizing, hey, we're starting to have a backup of fluid. We're getting increased venous return. Let's pump this stuff through, and it'll increase the heart rate to help with that. So next we have, which of the following correctly matches the drug with the receptor action in the airways? A, albuterol with muscarinic antagonist. B, isoproterenol with beta-2 agonist. C, muscarine with beta-2 antagonist. Or D, carbitol with nicotinic antagonist. Hey, you're missing the sound here. Let me get this going. It's eerily silent. There we go.
Yeah. Since being in Chicago last night, we were on the boat ride for the Region 3 conference, and Beyonce was playing at Soldier Field. So technically we were at a Beyonce conference. Concert last night. That's what we should be playing in between these questions. Oh, man. All right. So let's go through the answers here. Isoproterenol is, it says isoproterenol beta-2 agonist. All right, let's go through the answers here. Letter A, albuterol is a muscarinic antagonist. We know that albuterol is a beta-2 agonist. This is used to dilate the bronchioles, so this is not going to be correct. Let's go to C, muscarine. It says it's a beta-2 antagonist. We know that muscarine is an agent that mimics acetylcholine by activating muscarinic receptors, and so it's not going to be acting there on the beta-2. Muscarine is going to be a muscarinic, and so we know that letter C is not correct as well. Carbachol, same thing, is going to be acting on the muscarinic receptors, not on the nicotinic receptor. So we can rule that out. Last one here is isoproterenol, option B, as a beta-2 agonist. Again, beta-2 agonist, the beta-2 receptors are going to cause bronchodilation, which is the correct answer. We use isoproterenol, albuterol, both for these bronchodilation pictures. All right, last question. During which phase of the fast cardiac action potential does L-type calcium influx contribute to a prolonged depolarized state? And what is the physiological importance of this phase? So phase 0, it initiates rapid depolarization. Phase 1 begins rapid repolarization. Phase 2 maintains the plateau for sustained contraction. Or phase 3 terminates the action potential. Last question.
All right. So to understand this, let's just quick run through the actual potential here, the fast action potential. So in phase 0, you have the rapid depolarization when you have the influx of sodium channels that come in through the fast sodium channels, and that will drive that membrane potential from the negative way up into the positive. Then you start the whole repolarization process. So in phase 1, so again, phase 0 was the first part, and then now we start to go to phase 1. This is when you have an efflux of potassium, which is going to start to drop that membrane potential back down towards the negative. But you get to phase 2, which is the plateau phase. It holds up there because all of a sudden now you open up the calcium channels and you have an influx of calcium, bringing that positive charge into the cell to continue more of a positive membrane potential while you're having that continued potassium leaving. So it plateaus it. But then in phase 3, that calcium influx will stop and potassium continues to leave, which returns that membrane potential back down towards the resting levels. And then in phase 4, the cell is returned all the way to that baseline around negative 90 millivolts. And then you continue to have a little bit of that potassium permeability that got you all the way down to that level. So as a result of that, Tanner's question of which phase of the fast cardiac action potential does the calcium influx contribute to a prolonged depolarization state, now we know that that's going to be phase 2. It's where it maintains the plateau for a sustained contraction. That's the whole goal of the calcium there. All right, so hopefully these questions were helpful. Again, as we mentioned at the beginning, we've had a lot of people ask to maybe start doing some of these type of episodes. So give us some feedback. Let us know if it's something you want more of, if it's helpful while you're driving, exercising, etc. Just challenge your brain, go through a few quiz questions, but also some rationale of how you work through those questions. And hopefully this just gets you better suited to continue to pass different quizzes, tests, and then eventually boards.